time, then we'll actually let you guys go eat. So I saved a couple. We're getting a model that we use in the office too, so we can kind of show some of the anatomy and use it as an illustration. So I'm going to start with a couple questions from yesterday to hold off for Dr. Assadi and Dr. Cruciani that were pain related. One is someone had an occipital neurostimulator, which was surgically implanted to control the pain, not a TENS unit. Have you heard of this before? And if so, what do you think about it? So basically, the use of stimulators for occipital neuralgia or occipital pain.
Yeah, the use of peripheral stimulators are becoming more and more popular lately. The experience is building up. The first stimulator were implanted about 10 years ago on the occipital nerve to treat that specific type of headache. The experience, I would say, is mixed. I know patients that have done really well with it, and I know patients that it had to be removed. So the secret, I think, the important piece in this is the patient selection. Make sure that the patient that is going to get it is appropriate for this type of interventions. Do I recommend it? Yeah, depending on the patient, because I think that it can be really very helpful.
Okay. And another good question, actually, which is becoming very relevant. What do you think about medical marijuana for pain management? Someone is in a state where it's legal, and the doctor has referred them to it, and we had some discussion about this last night. We didn't smoke any, we just talked about it. Well, some of them I'm not sure. There's a couple people. But it's a good question, medical marijuana, and what are your thoughts on?
I was going to crack a joke, but they are recording it, so I guess I will refrain from
that's all right.
You never know if it's going to go to the web and what people are going to say. So I think marijuana, basically what it is a cannabinoid. And it's a combination of many different substances. If you look at the components of marijuana, you can isolate about 40 or over 40 different compounds. Some of these compounds are good for pain, manage pain, others appetites, but other gives you side effects and make you feel high and so forth. So what people are doing is trying to isolate the compounds that are good for pain and put them into a formulation that can help you if you take it as a pill or as a spray. So Savitex is one of them. We have experience on them. We were one of the sites when we treated patients for pain, and they did relatively well. So that's a strategy that definitely can work. My patients sometimes ask me, what do you think about medical marijuana? The answer to that is that I cannot recommend something that is illegal. I just can't. So if you utilize marijuana, if you find a doctor that can prescribe it for you legitimately, and you have your card, and it's helping you, and you don't have side effects, then I don't have a problem with that. I don't tell my patients you cannot use marijuana.
And that's the question. Legally their physician has recommended it and has given the card, and the question is, what are your thoughts on it? Does it work? Does it not work? Try it.
Exactly. Yeah. If I think that the evidence is that marijuana can help with pain. That's the evidence out there. Yeah. If you do it legally, and I wouldn't do it with a kid. I wouldn't do it with an adolescent. Only with adults, I would recommend to do it. But you have to do it, because the problem is if you do it legally and you have a card, and then you go out there because you run out or whatever, or you want a different type, and you get more marijuana. If you someone finds that out, and the police, it becomes an issue.
Yeah, but just to kind of get to the point, do you, legal issue aside, let's say and I'm sure it's going to become legal everywhere all the time. My thought on it would be, it's like from my experience, not my personal experience, but my experience with patients that have tried it, some people have, like any other medication, they don't like it, they have horrible side effects, it doesn't help their pain. Other people, it helps and it works, so.
Yeah, the evidence is that it can work on pain. So if legally utilized, I could say, if the pain is not well controlled, then definitely.
So that's a thumbs up. All right, Dr.
One thumb.
How much traditionally idiopathic scoliosis could actually be a underlying connective tissue disorder, Chiari or something like that? I guess that's for our pediatric. I didn't write the question. Don't give me that look. Here, why don't you come up?
Perfect. few minutes ago, I discussed the results of genome-wide association studies in Chiari malformation, and I mentioned 2 loci that have been detected. The one that's on chromosome 15, the gene that's called fibrillin 1, is a gene that's responsible for Marfan syndrome, which is a connective tissue disorder. So there is a possibility that hypothetically there may be a connection between connective tissue disorders and Chiari malformation. Although, as I mentioned earlier, you really need to have more whole exome sequencing or whole genome sequencing in order to determine that.
Okay. What holistic approaches are out there for children with pain who have Chiari and/or Syrinx? You can stay up, Mitra, stay up, because there's going to be a lot of pain questions that are.
Sure.
This is for everyone, for Dr. Cruciani, Dr. Assadi, anyone.
I'm sorry, what was
Mandy.
the question?
What holistic options are out there for children with pain?
Well, what I apply in my office is basically methods of biofeedback, cognitive behavioral therapy, relaxation therapy, acupuncture that are basically used for a variety of different chronic pain conditions in children and adults alike. So we offer that in our office, and I think for interventions that really are not invasive, they don't cause any side effects, they're pretty cost effective, I think they're pretty useful.
Okay. There's a specific question for Dr. Cruciani, and I guess this could be anyone, probably Mitra or Dr. Cruciani. Periactin for pain. A child, 5-year-old, was recently prescribed this, and they want to know how it works, and is it reasonable for a child to take this?
Periactin is a serotonergic medication, and it's used for headache prevention in children. So there are multiple chemicals that are involved in headaches. So headaches are caused by a cascade of chemical changes, and multiple different types of chemicals are thought to be involved, and serotonin is one of them. And periactin is used for that reason. Hypothetically, it does work in more than 50% of patients that have used the medication in, but a great deal of side effects that we deal with is number 1, weight gain, and somnolence. They are really limiting factors.
Okay. What are the chances that a Chiari patient will develop syringomyelia over time after decompression? Probably highly unlikely after an adequate decompression. I don't know if surgeons would disagree. I think if the decompression is done, it should be extremely rare. And if it does come, then you have to start thinking of other causes. This is a good question. And I think we have an adult and a pediatric neurosurgeon that can each answer this. How common are CSF leaks post-surgery? We'll start with Mandy.
Not very common. Usually patients might have a little bit of, if you were to image them, you might see a little bit of fluid that eventually will absorb on its own, but a symptomatic spinal fluid leak that requires reoperation is pretty uncommon.
Less than 5%.
Yeah, I agree.
Same, yeah. I mean, the 2 things we usually quote patients are infection and CSF leak, and it can happen. And even though it's a pain, but it's pretty easily fixed and self-resolved. How successful is the second surgery for research? That's too loaded of a question. It really depends on, why the second surgery, why the first surgery, what are the symptoms? Is it possible for a child to be born?
I think probably we should comment though on reasons for second surgery. So if you have a Chiari decompression that did not work, then first you question whether the symptoms are related to the Chiari. Then you look for whether the decompression was adequate. Does it look good on MRI? Third, you look for evidence of chronic instability, the basilar invaginations, those types of things. You look for evidence of pseudotumor, high elevated pressure, hydrocephalus. You look for evidence of tethered cord. It's unusual, rare, but so that you have to then question your original thought behind doing the decompression. If, for example, on the other hand, you do a decompression, it works great for 2 or 3 years, and then the symptoms come back, then the first thing I look at is the possibility of scar tissue, arachnoiditis, things like that. But there could be other etiologies as well.
Yeah, or the symptoms that you have just aren't going to get better. I mean, the chronicity of it. If you have weakness, if you have chronic pain for 10 years, and then you get a Chiari decompression, the longer you have the symptoms pre-surgery, so that's another option, is that it's just, the damage is done. Is it possible for a child to be born with spina bifida occulta and not be diagnosed? And can the birthmark at the base of the spine disappear later?
Yes, so about 40%, if not more, of children who are born with spina bifida occulta don't have a skin marker. They may not have much asymmetry in their feet. And so they could present later on with either bladder problems or pain or something like that. And those are difficult to figure out, obviously. Now, none of the marks that I showed you will disappear over time. However, there are a couple of subtle marks, like very faint hemangiomas in the back, which have a low association with spina bifida occulta, but not a zero association. Those could disappear over time. But none of the marks I showed you yesterday would disappear.
What, if any, connection is there between CSF flow and low resting heart rate or bradycardia? That's a good question. And can one drive the other? So connection with CSF dynamics and bradycardia.
Mark, you want to answer?
I did do, at Wisconsin, we did do a scan, a bunch of different slices. You know, then we did our axial flow scans at 7 different slices, and we had the misfortune to, the person in the scanner was a volunteer, was like a marathon runner type. That darn person had, you know, a heartbeat rate down 30 or 40, something like that. And extremely low CSF velocity, so low we could hardly measure them, which is kind of a disappointment. We wanted to, you know, actually get velocities we could actually measure and do something with. That was one person. If you kind of imagine if you have a heart, if your heart is beating slowly, the blood in your brain might have more time to vacate. So maybe not so much CSF gets pushed out. Yeah, that's just a hypothesis. Like I said, this is just one patient had just the really low velocities. There's a couple other people too who are, you know, pretty good shape. They tended to have lower velocities than say your couch potato types, but that's an impression. It's just an observation. That's just a few people.
And there are reports of bradycardia and severe Chiari, but that's more from probably brainstem compression. How are epidural injections used for pain? And I believe they said that Dr. Ringer had said that these were dangerous for Chiari patients.
Yeah, it depends on the where you are going to put the epidural, obviously. So if you are going to put it in the cervical spine, someone has to be very experienced to do that. I wouldn't. So it depends on where the nature of the pain is and where the surgery was done exactly. Yeah.
And lidocaine patches, are they good for pain or just temporary?
Temporary. It doesn't take care of the problem, but it helps. It's a type of patch that you put exactly where you have the pain because it acts locally. It's not like the fentanyl patch that will be absorbed and then work on the brain. This acts locally. So it doesn't hurt. The insurance company covers it. I would try it. If it works, keep doing it. Doesn't work, just abandon it.
Can you have an MRI if you have a stimulator?
The answer to that is no. Yeah.
Soon, hopefully. It's one of the things we have to work out because it's a problem.
Which is actually one of the reasons why the stimulators are removed when they don't work or when they don't work that great, just to make sure that you can image the patient when you need it.
And if you have a stimulator, you obviously need to get MRIs at some point, so it's definitely an issue. Is there long-lasting physiologic, not psychologic, but physiologic effects if chronic pain is not controlled? So the body's physiologic response.
The answer to that is yes. There are changes that occur in the brain and in the spinal cord, as we were seeing before in the slides that I showed. There are also changes induced by long-term use of medication. So both ways, actually, you are going to experience these changes. Are the changes are permanent? Well, in chronic pain, the more you wait to revert the pain, the more chances is that the body will take that as normal, and then it's difficult to revert. So that's why we try to be aggressive on the treatment of pain.
You're going to get bombarded here a little bit, Ricardo. During medication trials over years, a patient experienced serotonin syndrome. Where do they go next for, what's the next step?
Yeah, the serotonin syndrome, I have seen once, maybe twice in all these years I've been practicing medicine, and I use a lot of drugs that act on serotonin. So then obviously what you do is to avoid this type of medication. So I could say that if I have a patient with a serotonergic syndrome, I could go to anticonvulsants if they were not used before, and try to stay away from the antidepressants, particularly the old antidepressants or the SSRIs. The SSRIs in chronic pain don't work that well, so it's actually not much of an issue there.
Are there any good non-surgical options for an adult with pain and numbness from Chiari who's not a good surgical candidate? Everything's a risk and benefit. Not being a good surgical candidate is kind of a vague. I mean, if somebody's had serious cardiac issues, is going to have a high risk with anesthesia, has bleeding disorders, things like that. You have to weigh everything. If surgery is not an option, then I think a lot of the lectures you heard about Dr. Ringer's non-surgical remedies and really seeing a pain specialist, particularly if it's pain. If someone has Chiari along with Syringomyelia and scoliosis, but also had a serious trauma, can you determine where the Syringomyelia came for, and would it affect treatment? It almost doesn't matter. It's what you want to determine is if the Syrinx is from the Chiari, because that's going to change what you do. I think most surgeons experience, and I would open that up, traumatic Syrinxes are very difficult to deal with. And they're generally something we don't surgically deal with. What can be done with a young adolescent who has pain throughout the body after decompression for Chiari and Syrinx? What specialist should they see? That's actually a good question. Is it a pediatric? Is it adult pain specialist? Mitra, Ricardo?
You want to address the pediatric?
Who's the best person to see for chronic pain in a young adolescent?
Definitely Ricardo.
I would say that obviously a pain specialist with experience in young adults is the best way to go. No question about that. There are not that many.
I was just going to
so
say
it becomes an issue from that perspective. So I would say that I would try to find a pain specialist that is open-minded, just to good bedside manners to work with a child.
And somebody who understands pain. Going to a general neurologist is usually not a good step, or a family medicine doctor, somebody who has a real background in pain. Can a Syrinx fill back up after many years once it's collapsed? What could cause that? If it's post-surgery, the first thing we think of is that what you've heard over, there's scar tissue, arachnoiditis, reherniation. So that's where we go to the flow studies, because that gives us some information. And that's usually the first thing. If you've never had surgery and you have a Chiari and there's a fluctuating Syrinx, then that usually is telling you, again, there's blockage. So it's usually all about the flow.
Shunt malfunction might be a cause of that.
Right, if you have a shunt in place. What practices are being done to ensure that neurologists don't miss, but instead, basically to make them more aware of Chiari so they don't miss them? I think it's getting less and less common. I think it used to be. I know I saw a lot of it when I was a resident. I mean, especially with imaging. Getting an MRI, it almost hits you in the head, because most people are getting MRIs, and it's also a radiologic mission. It's not just a neurologist. You have to keep in mind that we're so subspecialized. Not every neurologist reads their own MRIs or even knows how to legitimately read an MRI. And if the radiologist doesn't call Chiari and they say it's okay, so it's multifactorial. But hopefully these types of organizations and conferences help. I don't know if any of you have any other. If you have Chiari and had a decompression, how long should you be following up with a neurologist if you're asymptomatic? Do you need to keep following up? I would start with the surgeons and then go down, because we're the ones who are going to determine whether they need to see somebody or not. What is your practice, Mandy?
So,
Asymptomatic post-surgery.
so if it's a patient, even if they don't have symptoms, but say they had spinal cord syrinx or swelling in their spinal cord like those patients I showed, I will follow them with imaging until I know that those changes in the spinal cord have resolved. And if they're asymptomatic after that, and a year or two out, asymptomatic, all of the syrinx and has resolved and they're well decompressed, then I have them follow up as needed.
Yeah, with children, it's a little bit different because with growth, changes occur. So we tend to follow them long term. So a yearly follow-up, and the only ones I actually scan are the ones who had a syrinx at one point.
So that there's mention of 2 months post-opioids if they're not working and you're still in pain. The question is, then what's next? Is there another way to deal with it if you're not responding to opioids?
Yeah, definitely. There is. The first is the question why you were on opioids at the beginning. Were other strategies tried before and they didn't work, or it was just the first approach? The other question is if there were opioid rotations. So what was the reason why the opioids didn't work? Was it related to side effects or not? Sometimes patients respond to opioids, and then you have associated side effects. In those patients, you may want to consider a pump or other intrathecal type of therapy. We went through the presentation through the options that we have out there, so I would say that you have to look carefully at the diagnosis first and see if there are non-invasive therapies that can be helpful or intervention that can be helpful, and then I will take it from there. Yeah.
Can you get syringomyelia from a traumatic birth, and what is the type of a traumatic birth? So our pediatric colleagues here.
I have to say that it's rare. I've seen one case, and still to this day, it was difficult for me to conceive how it happened. The child was diagnosed about a month out. So we assumed it's a traumatic birth. We just didn't know for sure. So I've seen one case in 17 years, so that's not a lot of patients.
How about you, Mitra? Have you seen it?
The thing is that birth is always traumatic. Hard
It's a good
to do
point.
it to the baby without
Especially, well, it's
trauma.
probably the mother too. I
So,
wouldn't know, but
It's, yes, to both. But I really think it's hard to confirm. And for you to determine that, you have to demonstrate other signs of birth trauma. Was there, for example, clavicular fracture? Was there hypoxemic encephalopathy? Other signs to
Right.
indicate that.
Right,
it was
brachial
something
plexus injury.
extraordinary. Yeah.
does pain control work better if it's continuous or intermittent? It's a good question.
Yeah, it is a good question. So it depends on the nature of the pain. If you have pain that is incidental, in other words, you are doing something that triggers the pain and the pain lasts only an hour, then take medication that stays in your system for 24 hours. Probably it's not the best way to go. If, on the other hand, you have pain that is continuous, that varies the intensity during the course of the day between a 7, an 8, a 4, then probably there you should be on medication that stays long in your system, like the long-acting formulation. So it really depends on the diagnosis and the characteristics of the pain.
Can a TENS unit be used in an area with sensory loss?
Yeah, there is no contraindication for that. You go above and below the unit. I'm assuming that the area of sensory loss has pain. And yeah, because you are targeting different type of fibers.
If you're a patient with syringomyelia, how dangerous is it if you have a bad fall or are involved in an accident? It's kind of, yeah.
Yeah, I mean, untreated large syrinx, I'd say there's probably increased risk because the spinal cord is partially injured, if you want. A treated syrinx that collapsed, probably the risk is not much higher. There's no evidence, of course, here, and there's a gray zone in between. So that's the best answer.
Yeah, I mean, I agree. I think you're definitely at increased risk, and this gets back to the age-old question of car accident patients who I never had a Chiari, I never had symptoms before, which is all true. you don't have as much space. You know, Chiari, you have a lot of high-priced real estate without any room. And when you have a jolt to the head, your reserve is much lower. So you're going to be much more prone to injury. So the Chiari was always there. The car accident didn't cause the Chiari for the most part. It just exacerbated a situation that was already there. Is there any point after which you would not consider, this is a good one to close with, would you not consider doing a decompression revision? So at what point as a surgeon do you say enough? Someone who has multiple shunts, everything else has been exhausted.
So, I like to have some radiographic evidence that a revision would be helpful. So, for example, on the MRIs that I showed where the cerebellum and the tonsils and the brainstem and spinal cord were well decompressed, if those patients were still having symptoms, I wouldn't know what my goal would be at surgery in those patients. You know, I have to be able to see something on the imaging to know what I'm going to achieve during surgery. So I guess my answer for that would be if the imaging doesn't give me a pathway to follow when I'm at surgery, then I wouldn't consider reoperating.
I would say the only caveat I would add to that is that if you've had really good result for a number of years, and then symptoms come back, but you don't see any problems on the scan, that could be scar tissue, arachnoiditis. And I have several patients that I've had to operate on who've had surgery a number of years before, and whose brainstem and cerebellum usually was stuck, and it could be stuck to the brainstem or to the dura. These are unusual cases, quite rare cases. That's the reason I don't personally coagulate the tonsils, because I think that maybe it increases the risk of that. But there is that potential, and it's very difficult to figure out because you can't really see anything on the MRIs.
Yeah, I think that becomes a very slippery. So, but I definitely think there's a difference. I think you see that much more commonly in the pediatric population over time. I think in the adult.
No, actually, most of the ones I've seen were adults who were sent to me by their primary neurosurgeon.
Yeah, I'll tell you, I've been, we've all been doing a lot of these, and I remember seeing a lot of it at CHOP and the kids, and I can't remember the last time. I mean, I don't buy into that's just me personally, I just don't buy into this whole arachnoiditis thing. I'm more of Mandy's philosophy that to go back and reoperate on somebody to find something, to me, what I've done in the past is I do flow studies, and I can tell you in the last 10 years I've done 2 cases that had, and you could actually see, to your point, you could see some of the herniation on MRI, and they had blockage of flow.
Yeah.
I think the patients that I've seen that have had 3 and 4 revisions, and they keep talking about the scar tissue and all that. If you have a completely normal MRI, you have great flow anterior and posterior, I don't know what I'm achieving. Like as a surgeon, we want to go in there and see something that we can fix. But I think the pediatrics are,
I don't disagree with you. I just can give you several stories of patients coming to me from elsewhere where their surgeon told them the MRI is normal, there's nothing for me to do here. And they'd been in pain in bed for a year, and then we take down their scar tissue, and they're completely functional and pain-free within a day or 2. I mean, it's not common.
But right, we agree it's rare. I think we all, right.
Maybe 1 a year, but it does happen. So, it's the same situation. Why are we doing flow studies? Well, because the MRIs are not good enough.
Right.
What about idiopathic syringomyelia? Does that mean there's no cause? No, there's a cause. We're just not good enough to see it. But it's very rare.
It's rare. I think the take-home message is that, anybody that's getting 14 surgeries needs to find another doctor. That's that simple, and I'll just leave it at that.
But if you remove the scar tissue, how long it takes to rebuild again?
I don't know. It's not very common. I can tell you that the vast majority that I've done have had only 1 operation by me. However, I have happened to be a child, that I've done 4 operations on, and then at the end I told mom I can't do it again because it's just enough is enough.
Right.
But the vast majority, it was only 1 operation. So
yeah, it clearly happens. It's just rare. So I think that answers. But you can see from these discussions that this is not, there's no book that we open up in these areas. Everybody's different, every case is different, and that's, why we need data and to collaborate. So we're going to go off to lunch now and stretch your legs, walk around. It was a long morning, so we'll meet back here at, John, what time are we meeting back? 2 o'clock.